Thank you. So let's call the board to order and welcome everybody. Just on some of the housekeeping matters, we have some apologies for absence at this board meeting. So actually, Suresh Viswanathan and Mark Walport, who were with us in this morning's private board, had to send apologies for this afternoon. And Mike Cooper sent his apologies for this morning's board and also, I'm afraid, for this afternoon's board. And let me also just announce is too big a word, but that Tanuj Kapilaswamy has actually tendered her resignation as a non-exec to the board. Actually, given the significant increase in her role and responsibilities at Standard Chartered, where she is not just a global head of HR, but also now a strategy and a series of other roles. And the travel requirements in that role have simply made it impossible for her to continue. But we will miss her. Sarah Jane, I know you have to leave just around about 5 o'clock, so thank you for being here. And if you just want to get up and leave at the right moment, that would be okay. So let's go declarations of interest. Are there any new declarations of interest that any board members need to share? Okay, thank you very much. Can I ask the board for its approval of the minutes of the board meeting held on the 6th of February? Any comments on the board meeting minutes? Okay, so we'll approve those minutes. I'll adopt those. Thank you very much. So if you'll humour me, because it's rather a bittersweet moment, actually. This is, I'm going to chair in my last board here now for NHS England. So I'm going to recite some of the activities that I've undertaken since the last board, but I'd also just like to share some reflections. Just to say it's been an immense privilege, an honour and a privilege to actually have been asked to chair NHS England. It's a critical organisation right at the heart of the way our society operates. It's a really important part of I think, what makes our country really brilliant, and that's the NHS. So to have had the opportunity to chair NHS England has been a huge privilege. It's been 3 years, quite challenging 3 years, lots of change, but also lots of challenge, which has made the job very interesting, but also, I think, perhaps the most demanding role I've ever had, but in many ways, perhaps the best role I've ever had. And it's been a privilege to work with the board. So previous non-executives who timed out, and then colleagues around the board table today. So non-executives, the executive team, working with trust chairs and leaders throughout the systems, the regions, into the trusts, engaged with primary care, engaging with many of the other arm's length bodies leaders. It has been a real privilege. But the best thing actually has been the number of times I've been able to go actually into the front line. I sometimes feel a bit performative, but actually to have the opportunity to go into the front line and to see the brilliant, passionate, committed NHS staff as they engage with patients, whether it's in ambulance shifts or on the front line in ED or in our acute hospitals or in primary care, meeting patients and doing patient Q&A, meeting the GPs and the other primary care practitioners. It has been, in many ways, the best part of the job, and it has been, as I keep using the word, it's been a real privilege to be able to do that, and I will miss it. We're joined today by Jim, incoming CEO, and Penny Dash, the incoming chair, is going to be joining us imminently. She's in another meeting at the moment, I think, with the department, and she'll be coming in as soon as that meeting finishes. So welcome to Penny when she comes, and welcome, Jim. There have been a number of announcements, really quite material announcements, as we know, since we last met as a board. The abolition of NHS England. Obviously, that's got to be managed through. It will take some time to do it, but the government's statement and intention to essentially abolish NHS England and absorb it within and work more closely with the department. We have the announcement of the new chair and the new chief executive. We have an announcement and the appointment of a new finance director, and also of a new transition team, and also very significant reductions in headcount, both at NHS England and at the centre, but also actually in the ICBs in terms of an expense run rate reduction. And so actually there's been a lot of news, highly material news since we last met, and it will make the next few months very challenging, in addition to the challenge actually of helping to run and organise and oversee and manage the performance of the NHS more broadly, and in its partnerships with local authorities, with the community, etc. Let me just, if you'll humour me, then just reflect a little bit on my 3 years. When I came into the role, I had sort of 3 broad themes. I often talk about prioritisation, and therefore trade-offs. I would talk about delivery. So it's really important that we deliver, we don't just talk. And then thirdly, I often use the phrase fact-based, that there's a lot of emotion and a lot of commentary around the NHS generally across our society, wholly understandably. And actually it needs to be factually informed. So really good fact-based helps, I think, better understanding of both the challenge and the opportunities. My second reflection coming in actually was just the sheer scale of the system is little understood, that it's an ecosystem and not a single organisation, often best described as a flotilla and not a dreadnought. And within that ecosystem, multiple layers of governance and multiple legal contracts, so hundreds of boards, each with their own legal and fiduciary responsibilities, thousands of primary care practices, private sector suppliers, local authority mutual dependence, and working within a financial system which allocates from NHS England down through the system, but which cannot by law run at a deficit. So it's a hugely complex ecosystem to engage with. And when I came into the role, there were a number of really quite stark factors at play. First of all, we were just starting the recovery from the pandemic. And that was a huge, huge task, where the health service had done an absolutely brilliant job through that period, but perhaps distorting some of its normal focus, and actually the recovery from that has been hugely, hugely demanding. There was a new structure being introduced of ICBs, so the 42 integrated care boards coming into play. Now they have emerged well and strongly, although lots of different challenges around them, and they each face different challenges according to the communities they face off to, but also this clear financial challenge that they have to manage. We also face a huge task of absorbing or merging with Health Education England and NHS Digital. Health Education England overseeing all education and training, initial and continuing across the medical world. And NHS Digital, just to give some sense for it, and now absorbed within NHS England, we now run live systems. So we run about 270 live systems which connect with 26,000 different organisations and 44,000 IT systems, and they are essentially overseen and supervised essentially through NHS England, having absorbed NHS Digital. As I've reflected on the 3 years, one of the things that strikes me most, and I come as a finance director from the private sector, is how well the money is actually managed. I realise there's lots of efficiency we can get, and we need to be more effective in how we do it. But actually, it's a very significant sum of money spread through that ecosystem, and I pay a huge tribute to Julian, sitting on my left, that has been managed over this period. The whole of the process has been managed within the money. It's not easy to do that. There's lots and lots of challenge in actually achieving it. But actually, the system has been managed well, strongly, financially. And within that, productivity has been central to our thinking. And if I think about the latest year, I think we're seeing an over 2.5%, perhaps slightly better than that, productivity improvement, made cost savings of £7 billion in 23-24, and we're targeting and will achieve over £9 billion of cost savings in the year, finishing actually at the end, effectively at the end of this month. So the productivity picture, whilst we have to do better in the oncoming year still, actually has been a record of performance. What else? So I talked about delivery. And I often recite delivery for the NHS. So in my first year here, Amanda and the team produced the first ever long-term workforce plan in the history of the NHS. A seminal piece of work, foundational piece of work that Navina leads on. We produced a long-term infrastructure plan, a capital plan, not published but shared with the Department of Health and with the Treasury, and that's very much the foundational piece of work underpinning one of the enabling groups of the 10-year health plan. And then if I think about other deliveries, and then I go into the recital around doubling the number of community diagnostic centres over the period, rolling out same-day emergency care into well over 80% of Type 1 hospital trusts now, urgent treatment centres. If you actually look at virtual wards, over 12,000 virtual wards, 12,700, I think, from a standing start, essentially 2.5 years ago, certainly taking treatment out of the hospitals and into the community. And then you look at the NHS App, turbocharged in terms of the number of subscribers and the functionality now offered and the connectivity with repeat prescriptions, or actually with appointments in acute and or in secondary care. The award of the FDP, essentially to a consortium but led by Palantir, which actually is getting our data across our acute hospitals interoperable and allows us actually to manage with greater effectiveness and efficiency and see a national picture on an aggregate basis. And when I talk about the NHS, I tend to talk in 4 themes. So I first of all talk about demand, and then I talk about capacity with which we meet that demand. And I talk about absolute record levels of health provision, and I talk about innovation. And if you let me just very quickly touch on those. Demand continues to grow, and very strongly. The population is 15% greater than it was at the turn of the century. It's older. The very good Aradazi report, in one narrative, cogently set out the challenge we see in demand, essentially from a growing and sicker society, so much greater obesity, mental health issues surging, cancer rates surging. And what we know in demand is that many of the causes of ill health actually are not, they're not within, if I say narrowly within health. They emerge from factors outside health: poor housing, deprivation, air quality, ultra-processed foods, alcohol abuse, gambling. So actually these causes of ill health impact the citizen, and then the NHS deals with whoever comes through those gates. In whatever condition, the NHS deals with whoever comes through those gates. And demand is up. And then our brilliant academic medical scientists find ever new ways to treat and cure and ameliorate conditions. So we also add our ability to meet that demand. Perhaps the most striking thing when I came into the role was capacity constraint. And so I would go around, and I still do, and I say that, we've got a third scaled to population. We have a third the beds of Germany. We have half the beds of much of Europe scaled to population. Our diagnostic capacity is less than half the average diagnostic capacity. That's echo, MRI, CT scanners, less than half the average diagnostic capacity for the OECD. And so you see that, and one understands that as demand grows, we meet that with a very constrained capacity. And our physical estate clearly is under very real pressure, with very significant backlog maintenance required. And we have workforce shortages in some key disciplines. And so actually the capacity with which we meet this demand requires real focus. And for me, the question is partly how do we build that capacity, incremental capacity, but better probably, how do we utilise the capacity we've got differently? How do we make sure that patients come into the right part of our capacity at the right time for the better treatment? And in that way, we can utilise that capacity better. And then the two last points I talk about, the absolute record levels of provision. Today, the National Health Service is providing absolute record levels of healthcare. More health provision than we have ever provided. And so with a huge tribute to the GPs and primary care, the fact that last year we did about 380 million primary care appointments. That was less than 320 million in 2019. So absolute record levels of primary care. Almost half of those appointments are appointments seen on the same day that the phone call or the online booking is made for an appointment, but mainly the phone call. and about 70% of those appointments are physical appointments. Last year, we did 3.2 million cancer checks and referrals. 8 or 9 years ago, we were doing 1.3 million. And so again, if you look at the volume of provision by the health service to the population, we are providing absolute record levels. And I say that I'm not being Pollyanna-ish. I do understand that actually we are in many areas not meeting the demand. We're not keeping up with the growth in demand that we're seeing. And in many areas, actually, we're certainly not meeting our constitutional standards. So there is much more to do. And I'm not being sort of either, it's the wrong word, vainglorious or Pollyanna-ish. There's much more to do, but at the same time, we should recognise that the health service is providing absolute record levels of healthcare. And then the last point I talk about is innovation. And I've referenced the NHS App, already turbocharging the NHS App. But if I think about genomics, we are world leading, amongst the world leaders, the NHS in genomics. Last year, 800,000 genomics tests, either whole genome or panel or single test. We scanned for 200 cancers and 7,000 rare diseases. We finished the whole genome, 100,000 whole genome sequence, and we've just launched the newborn sequence. And actually, we've started and initiated the National Genomics Research Library. So the UK, the NHS in England is absolutely world leading. And then I think about cancer vaccination. Last year, cancer vaccinations bespoke to the DNA of the tumour and the DNA of the patient. Remarkable. And again, I always look around carefully to my very able, esteemed medical colleagues, because this is where I go. My layman descriptions emerge, and I want to get them right. But I then often say we can imagine a world today, we can conceive of a world today, where we might have a fourth armament with which to fight cancer. So not just actually surgery and chemotherapy and radiotherapy, but vaccination. And vaccination is bespoke and tailored to the DNA of the tumour and the DNA of the patient. And we won't be able to do it for every cancer of every type, but we can see a potential where it might well become a significant additional armament. And then I think about robotic surgery. I think about nanorobotics capable of individual cell repair. I think of AI. So AI applied in screening and scans, in dermatology and histology, in brain scans, in breast and other screening. We have liquid biopsies, we have cytosponges, and this is in the last 2 or 3 years. And you think this is the NHS. And that innovation is really, really remarkable, and we can lose sight of it, I think, if we're not careful. So, what do I think as I leave? I said right at the start, it's been a real privilege to have this role. But if I was to finish with 2 things, one would be, there's often a comment we have more pilots than the RAF. I'm not sure that's really quite true, but we do pilot. And there are 2 pilot exercises which are really important, I think, in the last couple of years. And one has been a very thoughtful, cogent piece of work looking to pilot potential new models of primary care. And that could be revolutionary, I think. And it's very much caught up with and guided by sort of the fuller stock take, and then working from that and into neighbourhood teams and thinking of how primary care can act as the nodal point as we think about addressing particular cohorts of the population more proactively. And that's the second one. The second pilot is, can we think about who is utilising our constrained capacity the most? And can we make sure we treat them in the right place and free up that capacity? And that tends to be the frail and elderly and complex, but it's predominantly the frail and elderly. And when we look at what happens to us in the winter and we look at bed occupancy, so again, the stat the board has heard me too often online, sorry I repeated and it's a bit boring, but it's important. 25% of the population is over 65. They represent 50% of admissions and 74% of bed occupancy. And 25% of our beds in acute are occupied by dementia patients. And dementia has high correlation to age. And of those dementia patients, it's not quite 50, it's 46%, our data would share with us. 46% are in hospital because they've been brought in with a UTI or chest infection, which doesn't need treatment in hospital. Now, it doesn't mean that they don't have to be in for other things, but actually many of them should not have been brought into hospital. And if you think about that capacity utilisation, how we might free it up, that pilot in how we think about looking after frail and elderly has real potential, and it's revolutionary, I think, for the way the health service, I hope, will develop. If I was writing the 10-year plan today, that would be a key enabling step. It's not necessarily the end point in 10 years' time that you say that's my target, but for me it's the first and most important enabling step to allow us to get to that 10-year improved vision. And then lastly, I was going to finish just with, it's been, I think for me, under Amanda's leadership, and it's been an absolute privilege to work alongside Amanda, it has been a remarkable 3 years of delivery, actually, and of steady operational improvement in each of those years. So absolute record levels of healthcare are being provided today from an underinvested capacity, and at the same time facing fast rising new demand. And solving this equation, trying to keep up, it cannot be done by the NHS alone. Actually, it can be done if we do better cross-boundary working with a much better invested and run social care system. And perhaps, and this is where I get myself in some trouble, I think, with a more interventionist government on the broader causes of ill health. So actually, how can we manage causes of ill health better to reduce the demand that's coming at the health service? Otherwise, we deal with whoever comes through those gates. So thank you for listening to me, and I'm going to finish with huge thanks, actually. Amanda Pritchard, I was partly brought in to mentor you. It's actually been the other way around, to be honest. And Amanda, you're an outstanding chief executive. I said earlier I was a finance director in my past, and then I met a real one in Julian Kelly, who has been outstanding as the finance director. And Emily, where is Emily? Oh, there's Emily. And Emily, you, I'm not going to use my earlier description about being Cardinal Wolsey in Tudor history, but actually the way you have managed and balanced and engaged with the systems and the trusts and the operational oversight and the performance has been outstanding, and we will miss you hugely. And Steve Russell. Steve, not just carrying vaccination and screening, but actually much of the way that NHS England runs and operates is run by you. And it's a hugely, hugely demanding job. And you've done it absolutely excellently. And so we will miss you. So the four of you going, I think, is a huge loss for the NHS. But then actually, Jim, welcome to you. And then we have a new finance director coming in the transitional team. And when Penny joins us from her meeting, we have a new chair. But my thanks hugely to Amanda and to Julian and to Emily and to Steve. So thank you for hearing me on that. I'm going to hand Amanda to you now for Chief Exec's update.
Richard, thank you very much indeed. What an absolute tour de force of a reflection back on the last few years. Forgive me, colleagues, because I am going to just not let people get away without me saying a word about some of my colleagues who are stepping away as well. But I think just worth saying, of course, I will touch on it in a moment, but a lot has happened since we were last together as a board. So we will want to talk about some of that, and I'll just want to say a word or two about that as well, if I may. But before I do, I would like, I think, partly to echo what Richard has said, but just to say an enormous thank you to my colleagues who will be leaving us after this board. So Emily, I know you can't bear it. By the way, I know no one can bear it, and it's just awful, but I'm going to do it anyway. But Emily, from that extraordinary job you did for us in the pandemic, leading the COVID vaccine rollout, and then doing that thing that really great people do, which is say, OK, I hear it, your country needs you, I'll come back. Having stepped out to support Number 10 for a period of time, thank you. And then leading the delivery over the last couple of years to Steve, who then picked up the baton on vaccine screening, as we've said, first ever rollout of the RSV vaccine, as well as all of the other things that you've done as part of that programme, delivering the new NHS England programme. I know we're about to go again, but worth just saying that did release about £500 million of taxpayers' money into supporting the front line of the NHS, and we have already reduced by about 35+% as a result of that, and brought together NHS Digital, HEE, as part of our organisation. So a hugely complex programme of work.
Can I interrupt just on that point? No, And so that programme, we should just reflect. I'm sorry if I'm sounding a bit stats mad, but when those entities came together in July 22, it actually produced a joint headcount in essentially the head office of 24,000. And 20 months later, that had been reduced to 15,000. That 9,000 reduction is the source of the 500 million of freed up resource. It also debureaucratised a lot of the pressures from the centre down into the system. That number, 9,000, is probably, I think, the largest single public sector reduction that I've been able to find, the largest single reduction exercise. And it was carried out brilliantly well by a group of non-execs and execs working together. So Mark Cummins started, and Steve, you picked it up and finished that, so thank you. The numbers today are down further, so we've continued to reduce the headcount already. So the actual headcount is now a touch over 13,000 in that combined group. And now we have to go again with the new desires, effectively, to rationalise further the way that we operate and work ever more closely with the department. But sorry to interrupt.
Yeah, no, absolutely right, Richard. I will, and I'm going to go on and say just a bit more, if I may, about the change programme. But it was really just to acknowledge, Steve, your role in leading that, and also, of course, the hugely valuable learning from that, which we will now make sure is fed into the next phase of the work. To Julian, who has made an extraordinary contribution as not just Chief Finance Officer but as Deputy Chief Executive, including, and we're going to talk about this a bit later, driving significant productivity improvements post-pandemic, but also, which is less, I think, obvious, but Julian's role in many of the key strategic developments over the past few years. You've mentioned the long-term workforce plan, Julian, the tech and data agenda. Almost wherever you look, you'll find Julian's hands on it behind the scenes. And I was delighted to hear Julian's contribution recognised by the Secretary of State in the House recently when he described Julian as one of the outstanding public servants of his generation, which I think we would all agree with.
Indeed.
Steve Powis is not here with us yet. I know he's joining us a bit later, and this won't be his last board because he doesn't go till later in the summer, but I didn't want him to get away without having something said about him. So again, I just like to say from my perspective, the value of Steve's contribution, if we all remember those hard yards in the pandemic, and Steve really did reach right across government through clinical leadership, right into people's living rooms, as we saw him many times appear next to the Prime Minister at the press conferences. But he has gone on from there to oversee some really important work on quality, on safety, on secondary prevention, among many other things. So again, a huge contribution. On behalf, if I may, of all of my executive colleagues, I would also just like to thank our non-executive colleagues, because you have provided fantastic guidance, support, challenge over the last few years, and I know you will go on to do the same for Jim and for Penny. To Andrew and Wal, we said what we wanted to say about them last time, and they've had their last meetings, but obviously also to you, Richard. I did talk a bit at the last meeting about some of the things that you've done. You've also just talked about a lot of the things you've done in the last few minutes. But brilliant, because it's absolutely right to just take a moment to look back when you reach the end of the tenure. But I think, again, the thing I wanted to say is it's not just us that have noticed the contribution that Richard has made over the past few years. Again, fantastic to see that the work you've done, Richard, has now been publicly acknowledged with the Lifetime Achievement Award at very prestigious non-executive director awards just recently. And on a personal level, just thank you for the absolutely invaluable support you have given me over the last few years. It has been an enormous pleasure, a privilege to work with you, Richard. So for all of my other executive and non-executive colleagues who will be remaining on the board, Jim, Penny, I keep looking at an empty chair, which feels very unfair, doesn't it? Jim, Penny and the transition team that are coming in will bring with them enormous energy, expertise. I cannot think of anybody who could provide better leadership for the NHS right now, Jim, than you. But I know that you will all give Jim, Penny and the team the support that you have given us, and that you will bring some of that sort of organisational memory and some of the continuity from where we've been over the last years, which will complement that new energy and fresh perspective that they will bring. So thank you kind of in advance for what I know colleagues will do to support Jim and to support Penny. Oh, I should say, actually, Richard's just prompted me. We did say it would be Andrew. I did say a moment ago it was Andrew's last board. It was Andrew's last board before he agreed to stay on for another 6 months. So actually, Andrew is another really important part of providing a bit of that continuity and support to the team.
Amanda, can I just say a word? So just like Frank Sinatra, I'm coming back.
There he is.
But also, I just want to pay tribute to Richard for all the work he's done. So this man is a complete encyclopedia of facts to do with the NHS, a master of narrative, and he's been really, top class in terms of galvanising the board, getting it focused on a number of critical issues, and levering up performance. And he's been a pleasure to work with. This has been a truly, unitary board where everyone has a contribution, and you've always made sure, no matter what the point is, everyone has a say, which I think is really, really important. But your focus is on delivering the best possible care for the population of this country. And that has been, absolutely at the forefront of every agenda that we've had. And we have seen some improvements. So for the first time, performance against key targets has started to improve. So we did it last year, the same will happen this year. And that's all down to your leadership and the way in which you, worked with Amanda and got the whole of the NHS moving in the right direction. And the NHS is a blooming, big tanker, 186 billion a year, employing 1.5 million people. And it is moving in the right direction. And I think that's due to, some really outstanding leadership from both of you. So on behalf of the Neds, thank you very much. Thank you.
Thank you. Andrew, thank you. And I'm conscious just as we're reflecting on some of the changes that are happening at executive and non-executive level, and we get in a sense the luxury of having a moment to acknowledge that in this setting and to welcome our successors. I think if I just might move on just to talk a bit about the changes within our organisation, I am really conscious that we have an awful lot of colleagues who are feeling really very unsettled at the moment. So aware of some of those changes, aware of some of the bigger changes for the organisation, but you're not yet clear exactly what that is going to mean for them in their professional lives. So again, just to sort of say what I know I have said before, but to sort of put it, I guess, on the record, you all know, because I've said it before, that I do support the need for a smaller centre and for the department, for NHS England and for other parts of the centre to work better together, to reduce duplication, to drive priorities more effectively, and to give local teams in the NHS the space and the support to innovate and deliver for patients. Being able, we've discussed it before, but being able to pass a greater proportion of the NHS budget through to systems and the front line of we've consistently, I've just mentioned it, been trying to do and have done over the last few years is the right thing to do, particularly at a time of such significant financial challenge. And that's a challenge that is a global challenge, not just one for this country. And I hope that nobody in NHS England would disagree with either of those 2 points, the value of avoiding duplication and making us as lean and as effective as possible, or indeed the importance of passing resource on to the front line. But saying that, changes of this magnitude clearly do affect kind of everyone in the organisation, and I know that that will be at the forefront of the minds of colleagues who are staying on as part of the leadership team for NHS England over this transitional phase. And I do know, and you may want to talk about it a bit later, Penny, Jim, but I do know that you're hugely personally committed to making sure that things are done now as swiftly, as fairly and as sensitively as possible in terms of getting through that period of uncertainty. So that's important, I think, partly because these are our colleagues and hugely valuable members of the team. We want to look after people, but it's also important because we've still got a job to do. And a big part of the job at the moment, of course, is the usual stuff we have at this time of year, which is both the operational and financial delivery agenda. So the pressures of today and managing today, but also planning for next year. which is a hugely important exercise. Again, both of those things, Emily will talk a bit about the operational and delivery, Julian will talk about the financial delivery, and then Julian and Jim will talk a bit about where we are on planning. The other thing that we're doing at the moment, and this is really exciting, is we've got lots of colleagues contributing on and working with the department on the development of the 10-year health plan. And that is genuinely just a huge opportunity, not just for the NHS, but for the country, to set out a vision for the next 10 years and then a consistent delivery plan to support us actually getting there. So again, confident that Jim and Penny might want to say a bit more about that in their remarks. I should say we have I think covered most of those things, in fact all of those things in some way on our agenda today as we go through Richard, and indeed we've spent some time on all of those things at our private board before this conversation. But I think we will also just take a moment, as you just did, Richard, and Emily, Julian will cover as well, just to reflect back, because we are at year end now, on what we have achieved over the past year and what is still to do, and indeed what has been achieved over the past few years and where that leaves us. So there is an accompanying paper for this item, which is a written paper, but also slides which just sort of try and tell the story of the last few years in hopefully a way which is clear and helpful for colleagues. As I say, it's a bit of a here you go for some of the things we've learned and done well, but also some of the challenges that I think we would all recognise. So some of the things that we would call out, I think, if I may, you've covered some of these already, Richard, but following the enormous shock of the pandemic, we have virtually eliminated the longest waits for patients waiting for elective care and halved the number of people waiting over a year under your leadership, Jim. GPs, you've talked about the volume of activity that primary care colleagues are now doing, but we've also got now consistent improvements in the experience of access to primary care, and we're beginning to see the numbers of fully qualified GPs really increase this year. Lots of investment in training over the last few years, but now actually converting into the ability to appoint fully qualified colleagues in primary care, which is making a huge difference. Productivity we'll talk about properly in a moment, but in the first 9 months of this year, I think Julie will correct me if I'm wrong, but we now think that acute sector productivity is up by 2.7%. That is significantly more than double rates pre-pandemic. So just three things, but three examples of where I think real progress and, more importantly, sustained progress. And that's your point, Andrew. This isn't just a one-off. This is something we've been able to do over the past now 2+ years, which is a much better foundation for the next phase than where we were when we picked up post-pandemic. Important reforms that we've also delivered, from mental health teams now in half of schools in England to the thousands of virtual wards, meaning patients can get hospital-style care at home. I just want to call out a couple more. Martha's Rule, which I think we would now say has the potential to be one of the most important patient safety interventions we've ever seen in the NHS, already saving hundreds of lives, and I think will undoubtedly save countless more. And it's changing the way we work in a really fundamental way, because it's putting much more power in the hands of patients and families. And that is something we talk about. I don't like the phrase patient empowerment, because I don't like the idea that people should have to be empowered. Actually, the relationship needs to be the other way round with the health service. But this is a great example of really living that in practice and seeing that shift in the balance of power and the real benefits that can drive, both for patients and for clinicians. And then looking to the future, at the end of last year, end of 2023, I was really pleased that I was able to announce a life-saving and world-leading new ambition for the NHS, which was to eliminate cervical cancer in England by 2040, which was driven by a combination of HPV vaccination and the highly effective cervical screening programme. And tomorrow, I'm just looking at Steve on this, I think I am right in saying it's tomorrow, we're going to be publishing the delivery plan that sets out the next steps towards that ambition, including ramping up preparations to roll out or potentially roll out self-sampling to support many more women to access cervical screening. So we do need to do, or we know this, to do all we can to make those programmes more convenient for women and to make sure that those two things together, the screening and the vaccination, really do deliver what they clearly have, which is the potential to make cervical cancer genuinely a disease of the past, which is a completely remarkable thing to be able to say, but it is within our grasp to be able to actually do that. So, final words from me. I do think that the NHS has evidence time and time again that it has the determination, the skill and the innovative spirit needed to deliver that future, all the things that we're going to talk about, the 10-year plan, all the things that we're on the cusp of now. It absolutely does have the potential to do that, supported by a leaner but stronger and more coherent centre. And I would like once again just to thank all of you for your support, but also your determination to make the improvements that we know are necessary for patients and for staff, because it is not about stopping now, it is about using where we are now as a real launch pad for the future. And I would also like to thank you, as I've said, in advance for all the support I know you will give Jim and Penny as they lead the NHS forward.
Thank you. Well said. And that's quite a good segue in, actually, because I think, Penny, I'm going to hand to you and Jim, I think, just to share some initial thoughts, really, as you come into the role. So Penny and Jim together, I think, just to share those thoughts.
Okay, thank you, Richard. Very pleased to be here. Just want to start by, first of all, echoing Amanda's thoughts and reflections. I think some very exciting aspirations for the future, but also some real positive track record of performance over the last few years, and that's very much thanks to you and to Richard and to wider colleagues for delivering on that. I think three sort of things that Jim and I will be focusing on. First of all, changes to the healthcare system, particularly through the 10-year plan, and we can come back and talk a bit more about that. Secondly, have already been changes announced to integrated care boards, so really working with integrated care boards and with regions as well as with providers to think through how they collectively work together to deliver the changes that we all want to see to the system. And then finally, the integration planning around NHS England and the Department of Health and Social Care, where we have now established a programme board, and we will be meeting for the first time tomorrow, and hopefully able to then, out of that, describe what the process will look like and have some clear communication messages to support staff in particular, but also to reassure members of the public about how we'll be making sure that integration happens in a smooth and effective way. So those are the three things. I'll stop at that point because I'm sure Jim wants to say something as well. But again, thank you for all of your work and looking forward, though slightly daunted, to taking over the mantle.
Thanks, Penny. And I'll just add my thanks as well to Amanda and colleagues for all you've done over the years, but especially over this last few weeks. It's been an incredibly complicated period, and you've handled it as a true pro, as we would all expect. And, we spoke several times a day at times, just trying to stay on top of the complexity and focused on what we have to do. We're here for patients and staff. And that's been a key theme throughout the day, a key theme of our work in this next period. Acknowledging we're in a tricky place, but in March has been an incredibly busy month with an awful lot of things happening. But I'll just touch on a couple of things to give people hopefully a bit of a sign of some glimmers of hope for the future. So in the first few sort of changes in that week that led to the PM's announcement, on that day we met with chairs and chief execs across the NHS to discuss the planning round and the concerns about the planning round and progress and the potential for having a very difficult position going into this year. All of that was about a leadership response, and we absolutely have seen that leadership response. So I think we should acknowledge and thank colleagues for all they've done in this last couple of weeks. Absolutely. So right across the NHS, people have pulled together, and we now have incomplete but still much, much better plans going into next year. And over the next few weeks, we'll be working through that, the delivery risks and the things that we need to handle as we go through the year, but we're in a much stronger position now as a result of that leadership response. As has already been said, we've got a huge change for NHS England, Department of Health and Social Care, integrated care boards, but right throughout the NHS on the back of the announcements this month. And there's an awful lot of people very anxious and uncertain about that change. So Penny and I met with colleagues here today in Leeds first thing this morning. We've heard that. I just want to say publicly we've heard and acknowledged. We do acknowledge the uncertainty, the concern from staff about the change, the need for us to move with pace, but with fairness, with clarity as quickly as we can, and learn from previous reorganisations as well, where there's been a lot of that happen in recent years as has been described, and make sure we'll get through this period as quickly and as safely as we can do, not dropping a ball, because we've got to do what we've got to do as well as get through the change process. And then hopefully, and a few of us have been involved in 10-year plan discussions the last few weeks, Amanda and others before that, so we're a few weeks away from it being published, but I think those of us that have seen bits of it and had discussions about it, it will be really energising. So when people are saying to me, there's a lot of heavy lifting here, where's the hope, where's the optimism, where's the future, that's we've got that to look forward to. So I do think once we get through this tricky phase, finalise plans, etc., we've got more to look forward to, and a much more community orientated, prevention orientated, neighbourhood orientated, liberated health system that we all want to work in. And as been mentioned several times today, let's just remember the people involved in this, whether the patients that we're looking after or our staff. And we will, Penny and I, committed that today. We'll continue to stay focused on that, as you all have done over the last few years.
Thank you. So let me just, I'm going to say in advance what I'm going to say at the end of the meeting, which is I give you, but the whole board, which is you, Penny, and you, Jim, huge fortune, good fortune, good luck. You need luck, great commitment. You'll have the support. I know you'll have the support from the board and the execs, but all my best wishes and our best wishes to you as you take on these roles. But I'm sorry, I'm going to say that again at the end of the meeting as well, actually, all words to that effect. But thank you very much for those comments. Can I move us on? Can we move into just an update on performance, so both operational performance to start with, and then financial performance? So Emily, I think to you,
Thank you. Thank you, Chair. So this is my final report to the board as Chief Operating Officer, and I will continue the theme that I've been talking about for the last few boards, which is this is a report that shows both how impressive the NHS is at continually looking for improvements that matter to patients and delivering them, and that we still have a hugely long way to go. And I will try and reflect that in each section of this update. Because I can see that the NHS is delivering every day, not perfectly, not easily, but meaningfully and measurably in every corner of the country. I'll look at the whole of 24-25 just to put this in context. If we think back to the first quarter, we were still managing industrial action, we had a late planning round, and we had the ongoing operational pressures that we have most days. And now as we close the year, performance is better across the board, in urgent care, in elective recovery, in cancer, in diagnostics, in access to mental health. And that's not the end of the story, but it is a turning point, and primary care, sorry, I should have said. So I want to give an overview of where we are and how we got there. And in doing so, I want to pick out three themes I'll come back to briefly at the end around improvement, around data and insight, and around leadership. So if I start with elective care, in 24-25, we've moved decisively in the right direction. For the first time since 2019, the waiting list is shrinking. It's now at 7.43 million, which is down over 35,000 since December and 147,000 lower than this time last year. 65-week waits have fallen by 84% to just under 15,000. 52-week waits have fallen for 8 consecutive months, and we're forecasting that'll be at around 195,000 by year end. We've delivered this through surgical hubs, through 7-day operating, mutual aid, specialty level recovery plans, and thousands of clinical teams rethinking how they manage their lists. That's progress built on action. But the job is clearly not done. All of the numbers I've just read out are still too high. And returning to 18-week performance will be harder, requires a real rethink in many places about how local systems are managing their elective waiting lists. And so in 25-26, we'll need to go further into digital, into embedding productivity improvements, and to do even more than we have already, and into reproducible best practice and making the most of what we already know works. In urgent and emergency care, it always needs to be better, but performance is improving. So February's 4-hour performance stood at 73.4%, which is up 2.4 percentage points year on year. And Category 2 ambulance response times averaged 31 minutes, 22 seconds, which is nearly 5 minutes faster than this time last year, recognising that the flu peak has come at a different time this year than it did the year before. And that's testament to the work of thousands of people in local systems and, of course, the work that Sarah Jane's team have led nationally, building on the 2 UEC improvement plans. Having said that, those headline metrics have improved year on year, and the resilience of the system to cope against, particularly bad flu peaks, which we saw again this year, there are metrics where we haven't seen the same level of improvement. So 12-hour breaches fell 22% between January and February, but is still too high. And this is a place where I wanted to call out that variability in performance, because if we look at the last 6 months of data, 17.6% of trusts have deteriorated in 12-hour breaches, 25.8% have improved, and the rest have sustained their 12-hour performance. So even just bearing in mind that when we look at the headline numbers, we often miss both the improvement that's going on, but also some of the tensions that are happening and needing to be managed locally. The gains in UEC performance come from more core beds, at least in the previous year, but maintaining that capacity this year. The expansion of same-day emergency care, greater use of urgent treatment centres and virtual wards, and a much tighter focus on flow and discharge and operational discipline within UEC departments and into the rest of the hospital. And what we can see from the productivity packs that were shared with systems as part of the planning round is UEC still has some opportunity for productivity improvement, but much less, thanks to all of the work that's already gone in to improve performance there. We know what works, mostly. I'm sure there's more insight to come, but our task is now to do what works everywhere, and that requires capacity, capability, and brilliant communication. I'm going to not dwell on cancer because we've got a cancer paper coming in a second, and I'll leave the headlines for the team that are here to talk about that. I wanted to move on to talk about diagnostics, which is a story of really impressive scale and growth. In January alone, we delivered 2.51 million tests, which is the highest ever monthly total. It's been increasing almost every month since I've been in the job, since November 23. Our 6-week breach rate was 22.4%, and we forecast closing the year at 18%, which is a significant improvement on last year's 25.3%, but clearly still a long way to go to the 5% ambition, which was our target for this year. That really what's happened is, instead of the new capacity being able to bring down the waiting list, it's meant that we've kept pace with massively increased demand in diagnostics. And those expanded CDCs have delivered much better patient convenience, longer opening hours, pooled reporting, and better demand management. But the unscheduled activity demand has continued to rise, and so we are going to need to keep scaling capacity and digitising and modernising the diagnostic infrastructure to keep pace with the demand. On mental health, learning disability and autism, services have massively expanded the reach, and again, pressures remain. For example, over 2 million people were in contact with mental health services as of December, which is up from 1.94 million in March. Talking therapies exceeded the 6-week access standard at 91%, although recovery is at 47.5% against a 48% target. CYP access rose 5.2% year on year, reaching over 817,000. And dementia diagnosis rate is holding at 65.4%. That's been achieved through improving crisis lines, increasing perinatal services, school-based teams and workforce growth, which is now at over 155,000 FTEs. But we know that long waits in A&E for patients in crisis remain too common, although there's a brilliant improvement piece of work going on that now. And out-of-area placements in particular have not reduced this year at the pace we did last year and at the aspiration that we all had for this year. So 25-26 needs to be an ongoing improvement year of consolidating crisis alternatives, reducing unnecessary admissions and driving consistent quality across all services and geographies, because the 12-hour breaches that I review weekly are not consistently placed across the country. In primary care, we also have seen improvement despite increasing demand, and we can see that patients now are feeling a sense of better access. So in January, general practice delivered 33 million appointments, which was 5% higher than last year. But perhaps even more importantly, satisfaction by patients with ease of access has risen from 60.9% to 73.3%. Still a long way to go, but much improved. Pharmacy First has continued to deliver this year with exceeding targets on contraception and blood pressure checks, and clinical consultations are rising. But as is widely reported and a source of much discussion across NHS England and the Department of Health, dental access remains a huge concern, with 78% of activity delivered in December and continued difficulty in new patient access. In the community, virtual ward capacity is now past 10,000 beds, and the urgent community response is hitting 84% on its 2-hour response targets. But the waiting list has grown to over 1 million, with long waits concentrated in children's services, particularly, worryingly, in community paediatrics. So the priority for the next year is clear. We need to reduce variation in access and experience. We need to expand integrated neighbourhood models and continue the contractual reform that's needed to unlock primary and community capacity. So where does that leave us? We've got elective waits coming down, we have urgent care improving, we have cancer progress moving even faster, we have diagnostics delivering at scale, and mental health and primary care reaching more people more effectively than ever. We've got a system that's recovering, not evenly, not completely, but steadily in the right direction. And so 25-26, in my view, although I'll be leaving it to other people to make it happen, is the year we need to go more precisely on actions in the way that I've just spoken and in those 3 categories I spoke about earlier. First of all, in embedding improvement capacity, capability and confidence locally, moving from knowledge of what works to actual consistent delivery across the board. And we need to hardwire that improvement into the way that we operate every day, including in reporting and target setting. On data and insight, we know a lot about performance. We track an immense amount of data. We're getting better at getting insight from it, and that this year that included work across our analytical teams and with academics to identify the actual root causes of underperformance as opposed to what we tend to think it is based on experience. There's work underway to build that understanding into a diagnostic that will allow more effective, focused support to the most challenged systems and making sure we're addressing the real underlying root causes of underperformance. That needs to link into the assurance and regulatory approaches that Steve and Adam will talk about in a minute. And then finally on leadership. A lot of this is about leadership. It's not all about leadership. It's sometimes a bit of a convenient phrase, but we know from talking to CEOs across the NHS that taking on the most challenged systems, the most challenged organisations is not always attractive or rarely attractive. And so I'm looking forward to the work that's been done by teams across the system to identify what does it take to get the right mix of leadership skills into those most challenged systems so that we can support staff to make the improvements that they can see need to be made and that they want to make, and make sure those systems are improving in the way that we would all desire for service users. I want to close, you'll be grateful to hear, Richard, by thanking colleagues across NHS England, including the regions, and above all on the front line, because the recovery we've seen this year is thanks to everything that they've done. I'm handing over with confidence and optimism. There's more to do, but we know where we're going, and I have confidence in the people that have done all of that work, that they can see where more needs to be done, and they'll be busy delivering it today as every day. Thank you.
Emily, thank you very much for a fulsome report, actually. It's important sometimes, I think you and I have talked about it, to share some of the detailed factual evidence behind some of the statements, and thank you for doing that. So clearly, I'm going to ask Sarah Jane in a moment just to reflect on winter, the lessons from the last couple of winters, actually, and then looking forward. But before I do that, any comments or questions for Emily on the operational performance? Andrew?
So if you just stand back, we're trying to aim for a kind of step change in performance on 4 hours and 12 hours. 12 hours, I think, is more important from a kind of risk management point of view. And if we don't do something very, very different, we'll never hit the elective target downstream, because you need that capacity freed up to do more elective work potentially. And we put in a hell of a lot of resource to support organisations, and just going forward, what is it that is going to give us that step change? Because I think at some point we're going to have to talk about a 5% betterment per annum, right? Which is where we were at the beginning of the century, right? When we were faced with the 95% target for 4 hours. So it's just trying to understand that kind of landscape and what's required going forward. Because without that vision, we're not going to get there. We're going to be still talking about a 1 or 2% kind of incremental growth. And I think that's the challenge we've got at NHS England, is just trying to set the scene for the future and be clear about what are those kind of big step moves that we need to make.
Yeah.
Well, I was wondering if it was worth holding that until Sarah Jane's
Sure,
had a chance
sure.
to talk about
Okay,
lessons learned
sure.
and looking forward. Yeah.
Yeah, okay. So, Jane, do you want to comment about
Yeah,
past
absolutely.
winter and the winter before? And
That's the big question, I think, in all of this, obviously, as Andrew's always spot on with. So in terms of the winter, Emily covered, I think, really well the sort of picture overall. I think the areas that we have seen progress in is that consistency and just ability to be able to step up and respond, particularly to acute needs in the community. So our ambulance response times, and also being able to get alternatives to conveyance and admission in the community, which has really started to make a difference. I think the area that we've really struggled with over winter, and again it's been very visible in the data, that as we've really driven to get our ambulances out back on the road, that has meant that some of our emergency departments and then wider parts of the hospital have been overcrowded at times, and that has meant that patients having to receive care in corridors and other areas that are absolutely suboptimal. And I agree with Andrew that whilst we need to achieve the 4 hours going forwards, that is the thing that we need to provide a huge focus on every day, but obviously it becomes more acute and challenging in winter. We will be sharing a UEC delivery plan in coming weeks, which will be our short-term approach essentially while we wait for the 10-year plan, because I think many of the sustainable solutions that answer your challenge sit in that plan, and how we think very differently about community and neighbourhood and our relationships with social care and so on. But we've got probably a whole year of delivery here where we're not going to have that, and therefore we need to get really focused. If you take Emily described the organisations that have improved, and certainly the ones we've worked with, there isn't one thing you can do. Even if you load lots of new beds into a system, if they're not part of a whole integrated flow, they make a difference for like about 7-10 days, and then everything silts up, and in a way they make the problem worse because there's even more patients for an infrastructure that's overwhelmed. So the key things there are every part playing their role, so from primary care, 111, ambulance services, not taking patients to hospital unless completely necessary, community services being scaled appropriately. We often see absolutely beautiful examples of what a UCR or a virtual ward or a neighbourhood team can do, but they don't do it consistently for every patient every time, all through the day and night, and we need to build that consistency. But we do also need to be honest with ourselves about what is going on in hospitals themselves. And the organisations that deliver the lowest 12 hours and the best 4-hour and 12-hour performance, the medical model of care inside the hospital has a huge focus and priority on urgent and emergency care, and patients are reviewed consistently with continuity, and decisions are taken that take those patients forward in their care every day. In some of our most challenged that we have gone to as part of our improvement, it can sometimes be days before a patient is seen by the specialty that is the one that's going to be able to take their care forwards and resolve. So this is really linked to productivity, it's linked to the relationship between UEC and elective, but if there was one thing that was going to unlock this for the winter coming, it would be that. But I do not want to lose the broader landscape here, because this is definitely about what happens in community and discharge as well.
It's back to Emily's point around the leadership challenge in certain communities, where you get leaders working together and, you know, re-gluing pathways, you get a lift in performance potentially, where it's a bit more kind of fractious. You just don't get it.
But we're looking for that drumbeat. We're looking for we've got a saying in ESIS, the improvement team, that consistency beats brilliance every time. And there's so many people doing these really brilliant things inconsistently. We just need every day to do the steps that everybody takes in their care. And that's why our handover delays, and there are more patients in corridors at the beginning of the week than there are at the end. That's because we don't have the consistency, we don't have the clinical and operational standards and execution that we need. So that will be a big focus of the delivery plan moving forwards, and then what we'll do to support trusts and systems to get in the best place they can.
Julian, you want to ask her? Make a comment?
I've got a reflection and a question. I mean, I think the debate about over the medium term, how do you achieve those step changes, I think it still has to play out. I think there is a question where you might need some more capacity, even with like a significant left shift and a change in model, because nowhere in the country is delivering against the constitutional standard, and with an older population, I just can't believe that some extra capacity is not going to be needed to provide some level of kind of decompression. But like that's the debate, absolutely, that needs to be had, I think, as part of the spending round. But I am really struck by the fact that if you look over the last 5 years, when you look at demand, sort of emergency demand, and you look at admissions, we're basically sort of flatlined against, even with the sort of increase we've seen, and you know, against the level in 1920. Now, if someone had said that's what would happen back in 2019-20, you thought, well, that's extraordinary. Now, I know we had a big change through COVID, big shock to the system, but over the last 6 months, we've sort of seen a flattening in demand. And my question is, do we understand why that is? And is it actually the work that's already been done to achieve some of that left shift in some of our systems, or indeed the work we've led nationally through things like urgent crisis response and the virtual wards, even if they can still work better? Or is something else going on? Because similarly, if you look at elective referrals, I think one of the striking things this year is clock starts have not seen the growth you would typically expect to see, relatively flat. And again, is that evidence of, the stuff we have worked on over the last few years around pre-referral advice and guidance and so on, or is something else going on, and what's our view?
Can I just reinforce that as a question to Sarah Jane, either to you or clearly to Emily, and also if you can pick up Andrew's comment more. It is that question, is it, because when I go into acute hospitals and I go through ED, and it is the profile of the patients, predominantly elderly and frail, actually, are waiting. and they're often the ones who are either in the cubicles waiting to be admission or on trolleys. And yet, at the same time, Julian's asking about this flattening demand, and have we got data or clues that would say it is the introduction of urgent community response? So it's the Cat 2B elderly falls categorisation with ambulance call-outs. It's the virtual wards, which have been around now for a couple of years. The utilisation of the virtual wards, are they by the elderly and the frail more in step up and step down? And are these the things beginning to make the difference? What do you think?
I don't have a well-researched academic answer for the whole country, but I do know that wherever we go, because we try to take the DNA of the high-performing system as well, and that is absolutely the case, Richard. They have focused on frail older people. They've got some sort of approach to segmenting the population, and it's that every time approach to that group of patients. And there are some places, I know you visited one, that have arrested the increase in admissions for over 65s. By way of example, I was at Washwood Heath last Thursday in Birmingham, where in East Birmingham they've got a population cohort that they're managing, and again they've seen a big reduction in admissions there. So I definitely think this isn't just something that we say and we don't really know whether it impacts. I go back to the corridors. A third of the patients in the corridors that are waiting for care are frail older people that should have had a better response in the community. They're over 80 years old, and many of those patients go on to be delayed discharge and need to leave hospital with a higher level of need than when they arrived. And if we can get it right for that group, we're not just helping capacity and flow and everything else, but we're also helping massively with social care and continuing healthcare spend as well. And some of our best examples, there's not just been huge productivity gains for the NHS, but there's been huge savings for social care as well. So there is a way to get this right, but you do have to make the shift and the investment in the frailty pathway up front for this to work. It's not that the patients don't need anything, they're just better served in their care home or at home. So we should have confidence that we can do this from the examples that we've got, but it's a big cultural shift as well as everything else.
Emily, your response, just reaction to the conversation we're now having?
I wanted to pick up something that Sarah Jane said, which is when we look at systems that are consistently higher performing and the ones that have made the biggest difference, where often Sarah Jane's got teams in there doing some of the work, it isn't just one thing, it is everything, because this is a system collectively across the country which is at its limits. So there isn't a magic bullet, because if there was, we'd have done it already, right? This is about flow through the hospital. It's about the relationship with social care. It's about the right frailty services in the community. It's about primary care and making sure people have access. It's about the right level of hear and treat and see and treat and the ambulance trust. I won't keep on listing it. It's mostly a test from Sarah Jane to see if I've internalised it all. But so that is where it comes back to Andrew's point, because some of that can be achieved within a single organisation. A lot of it can't. So it is about the right leadership inside the organisation. If I think about one of the systems that was perhaps the most troubling when I arrived in November 23, what made the biggest difference there was actually getting the clinical leadership of the trust and the managerial leadership of the trust working together in a completely different way. That was the first step, but the second step was getting the rest of the system to pull its weight to make sure that that particular part wasn't being overloaded. And within that, there are all of those sort of specific operational improvements we've talked about. So that goes back to Julian's point, which is to say, I can't see a sunlit upland where you can do all of this and not put extra capacity into this part of the system. But I think it remains to be seen, the way in which the 10-year plan, not just what it says, but how it's planned to work through the system, because we can definitely do more to keep people from having to go to A&E, and yet lots of people are going to end up at A&E, and we have to make sure we've got the systems to manage both.
Thank you. So, so I'm going to go Mary, then Mark, and then Steve, and then I'll move us on to finance, I think that's good. So Mary?
Thank you very much. I completely agree that a lot of people are being admitted to hospital who'd be much better to be at home, and their homes are their care homes quite often.
Yeah.
So I wonder whether in the next few months we might do something about really focusing on a handful of people who've managed to stay at home, and learn what it is in more detail to share best practice, to show others what can be achieved. And I think we talked briefly this morning about there are quite a lot of care homes that are very nervous, for example, of having an infusion for a period of time, maybe to give intravenous antibiotics. And yet a lot of people who live in their own home are quite comfortable with that if they've got a district nurse coming. So there's something about showing what we can achieve to the public so that their first response isn't actually, and quite often this is people's response, I want somebody to go to hospital because then I don't have to worry. And we should somehow make it that they don't have to worry because we're giving enough support in the home.
Thank you. Mark?
It's a sort of talking about this flattening of the line and the flattening of demand. The one bit that is not flattening is patients in contact with mental health services, which seems to be on this sort of not quite exponential but not ending growth. And I suppose there are two questions. One, do we understand what the underlying driver is, and do we have any hope this will tail off, or do we think we are facing into sustained and systemic long-term demand? And two, given shortage of long-term investment in this area, what effect is that happening on UEC and other pathways?
So can we hold that question? Steve, do you want to come in?
Yeah, just very briefly, Richard. It's like a minor fly the flag moment. So Amanda mentioned the RSV vaccination programme that was introduced this winter. Colleagues may or may not have seen it, but I thought it was worth a couple of seconds just to sort of underscore the point that Sarah Jane often makes, which is it's about getting the basics right. That applies both in hospital and out of hospital, and one of the basics is vaccination. Yeah. So we managed to vaccinate since the start of the programme about 1.8 million people, of which about 1.5 million are the older adult cohort. And UKHSA published a early evaluation earlier this week, which I thought might just be of interest to colleagues. And what that showed is that in the 75 to 79-year-old group, hospitalisation was 30% lower than in the other age categories. Now, that's not going to flatten the entire demand curve, because the population of 75 to 79-year-olds is not the entire population of England, but it is a group of people who make up a significant proportion of the population, and often, to Sarah Jane's point, have other comorbidities. So the reason I guess for highlighting that is, although that is good news, there will be more people who turn 75 this year. And we need to make sure that all of those people that turn 75 this year are offered the most convenient access to vaccination. It's something that everybody thinks about, because if we get all of those new entrants to the cohort vaccinated before winter, that will mean their chance is 30% less of being admitted to hospital. And similarly, we've still got about 5,600,000 people who were eligible at the start of the programme who didn't have a vaccination by sort of the end of January. So that was maybe a little bit longer than you thought I was going to say.
That's very good. Thank you.
Worth highlighting.
Worth highlighting. Can can we back? Actually, there's one. It's the question on mental health, or the questions for Mark. But before that, Jane, you want to come in? I think.
Yeah, just super quick, actually, really just to reflect. I mean, there's an opportunity coming up with the publication of the 10-year plan to also have that conversation with the public about how they interact with the NHS and the things they can do around their own health and all of that sort of thing. And I think that's such a great example of where, something is being offered to people that I know from my background, WHO, millions and millions of people around the world don't have access to, and die as a result.
Yeah.
So I think it's just, I hope we take that opportunity. I'm sure it will be taken when the 10-year plan is published, to also have that conversation with the public, that these are things that, as I say, the vast majority of the world's population don't have access to, and to encourage people to do everything possible to help us to support them in the way that we want to.
Okay, well said. So, Emily or Simon, do you want to have a go at Mark's question?
When I come in from an operational perspective, and Simon may want to, if we do it that way around.
What's driving this demand?
Well, I think the... actually, when you talk about demand, and I'll come back in on what we're doing about that way around.
How charming. Thank you, yeah. Well, I mean, there are two things. One, you can see that more people are accessing. That's been going on for quite a long time, and it's still steadily increasing. But it's not increasing enough to cope with increasing demand, and I don't think it ever will be, because I think it's made up of several different aspects, as we've talked before. One is genuinely better recognition of some disorders. Other is changing diagnoses, which we do from time to time. Very irritating for people, but we do. But the other, I suspect, is a mission creep as well. That's going on in relabeling of other issues and disorders as well, which is something that we won't ever catch up with, and you might possibly argue perhaps we shouldn't, because it's not necessarily going to be solved by antidepressants or talking treatments. But quite how we unravel that is a major problem.
Yeah. So we talked earlier in the year about the strategy around that, which needs further work, and I'm sure that will be in the 10-year plan, at least partly. I think what the NHS is, in terms of what we're delivering every day, we are seeing increasing delivery, and I mentioned some of the targets earlier, and I'm just looking in the longer paper at the children and young people receiving more than one contact, and then the children and young people's eating disorder pathways, where in December we saw 81.9% within 4 weeks. That's a big improvement on the previous year, but it's still nearly 20% of children in need of eating disorder services who are not being seen within 4 weeks, which I can only imagine what it's like if you are that child or the parent. So this is a case of, we do clearly have to do more on capacity, but that is a combination of more capacity in the place where it's actually needed, combined with the clinical judgment that Simon's mentioning, and also making better use of the capacity that we've got. So we know, for example, that our length of stay in mental health beds is much longer than it used to be. It's also much longer than other countries with similar populations. So there is an opportunity to make the most of our capacity while we figure out what is the right mix of capacity growth and clinical decision making in order to address the huge pent up need that we're seeing from the population.
Thank you. I'm going to, slightly conscious of time, move us on, but thank you for the update, and Simon, thank you, and Sarah Jane. Thank you very much. So, and also just to welcome Steve Powis. I know you only arrived late, we were at the Public Accounts Committee, so I do understand you had a...
The pleasure of the Public Accounts Committee this morning. I have the pleasure of the board this afternoon.
What a lovely day you're having.
There you are.
So, Julian, financial performance?
I'll take the paper as read, but the headlines are... as of the 27th of March, we are forecasting to live within the NHS mandate, as I've said we would. At the moment, we forecast to underspend it by 25 to 50 million. There's a few things we'll no doubt go through as we complete the accounts at the end of the year. With respect to the NHS as a service, we will end the year with integrated care systems 600 million off plan. That compares to last year when we were closer to 1.5 billion off plan, and I think shows there's a long way to go, but the sort of super tanker is turning in terms of, just kind of the real hard yards of financial discipline, the recovery of productivity. 25 ICBs will be on plan, but that means, the residual aren't, and that is, the detail of that is set out in Annex A. I think what is striking is, we have seen significant headcount growth this year. When you take total sort of the total WTE position, and I include in that both substantive and temporary staffing. We've seen an increase in substantive staffing, but in total, the pay bill is down. So year on year, the pay bill is down 0.7%. That is actually a shift compared to previous years, and that is basically because as people have recruited, they are taking out the temporary staffing costs. We are seeing that particularly, again, on the agency bill this year, where we are forecasting total agency costs this year of about 2.1 billion. By the way, compared to 2 years ago, that is like where it was like more like £3.5 billion. So that really is a shift, and I think probably about the lowest it's almost ever been, not just as a percentage of payroll, but actually in cash terms as well. But look, more hard yards to be done next year. Productivity is up. So we've published a paper today as part of this report that shows that, consistent with what we have said all the way through, and despite the fact that I think that people have been concerned that NHS productivity is still falling, after the sharp fall in 2021, a reasonably sharp rebound in 21-22, the ONS, as you have said, have published their latest sort of gold standard analysis of public sector productivity and health productivity this morning. That shows that the NHS in England saw an improvement in productivity of just around 2% in the calendar year 22-23. By the way, that almost precisely matches what we have said and the measurement we were making. Our data would say we have continued to recover through 23-24. As Amanda said earlier, acute sector productivity is up year on year 24-25 by 2.7% through to the end of December. Actually almost 3 times the historic rate. We are publishing for the first time non-acute sector productivity data covering mental health, community and ambulance trusts. And again, that is showing, we think, around the same level of productivity improvement year on year 23-24 to 24-25. Now, the ONS data, by the way, shows that at the end of 22-23, the gap to 2019-20 was about 5%. Now, there are 1 or 2 technical things which will change, but I think broadly, if you were to look at that today, for the total NHS, I think that would probably show you around 3 to 4% gap today, and therefore a real chance to kind of close it as we go through next year, again, with the right focus.
So that's recovering from the productivity challenge of dealing with the pandemic.
Yeah. And look, as I said, you can see the kind of just getting back the kind of basic discipline. I mean, it's worth remembering that even before the pandemic, NHS finances were significantly stressed. I mean, as in a previous life, when I was in the Treasury and working with
on the
dark side, and we're working with Jim to kind of wrestle. At the time, provider finances underlyingly, had sort of deficits of around £3 billion. So it shows this is a long-standing issue. But look, I would say green shoots of recovery, but a lot further to go. Now, looking ahead, we have had back today the sort of returns about people's plans for next year. On the positive side, I think we've got 37 systems who are showing plans to kind of live within the money that we have said is available. We have 5 systems: Cheshire, Devon, Sussex, South West London, Greater Manchester, who are still showing they have a gap to plan of about £300 million. Now, I think that is better than we had thought we might be, and I think that's a testament to a lot of the work of people throughout the NHS, including in NHS England, and I think it's also a reflection of the work that Jim has also been doing, and some of the stuff that's happened over the last 3 or 4 weeks, where people really have clocked, no, the money is the money. Now, I think when we really go through those plans, we're going to discover a couple of things. One is there is still further to go in turning things written down on the spreadsheet into an actual plan, and that there is still further work to do, because I suspect what it'll show is people think they can sort of keep emergency performance improvement sort of steady, rather than the sort of shift, Andrew, that you were talking about. And I think there is still, we will still find there is a way to go to really nail down with people how they can show the improvement in elective performance that the government is clear as a must do. And I think that is the work that the team have planned with Jim, in particular, over the next month. And I think the critical thing is getting away from negotiating about the money to nailing down like what is the actual action. And I think there's a chance to do that in particular over the next month. In support of that, actually a real focus on productivity is the key. We were talking in the private board about, the challenges of the future, and you can see a way through if pay settlements are sensible, with real terms growth in NHS funding, as long as we can deliver kind of 2% year-on-year productivity plan. Now for next year, 25-26, we had a set of proposals. We have a plan which is to focus on training 20,000 managers in just the kind of basic operational management skills, in providing and investing in improvement, clinically-led, senior clinically-led improvement support that could potentially cover, in different levels of intensity, up to 50% of our trusts, the ongoing work on technology, and as I said, just a real focus on improvement. If we could, as I said at the private board, the one thing I would invest in and make happen, if it is at all possible, is basically rolling out ambient voice technology, because I think that we know is it is not a complicated thing, Mark, as you were describing earlier. It can be done, and we know it can be transformational, both in the way that clinicians can interact with patients, but also just it's just time saving, just to automate the basic admin tasks. But anyway, that's where we are as we look, as we close out this year. So solid improvement, further to go, people taking seriously what they need to do for next year. But I think, again, further to go to turn it from ideas on a page to actions we can all be confident in.
Okay. Jeremy?
3 quick things, Richard. First of all, thanks, Julian, for all your hard work while we work together. Secondly, just further field, I was going to ask a question on short-term productivity. Longer term, any input to Penny, Jim, and your successor, Julian, on longer-term productivity going into the 10-year plan opportunities? And thirdly, would you like a job with Marks and Spencer's on forecasting, because it's very accurate and more accurate than ever?
Take them in
Probably a
reverse order.
second question you can add.
No. I won't say which question I'm answering. Look, on the sort of longer term, I actually think it is you've got to get the basics right. You've got to get people with the right skills, with the right support. Without that, all the fancy stuff, I think, doesn't really work. And it goes back to some of the stuff that we were just discussing about how we can honestly improve urgent and emergency care. A real focus on whole system working, because in the end that is the thing, we're joining it up right across the piece, and the role that I think commissioners have to really make that work is incredibly important. And then if we can do those things, and by the way, there's huge potential, if you look at some of the productivity data we have given, even around mental health and community services, there really are gains, huge gains that can be made. But then if we can get the basics on the tech right, I think that is the thing that shifts the paradigm. And half the gain of the future needs to come through investment there. It's like consistent, repeated investment in that area.
So Julian, thank you. So it sounds like the initial submissions, which are pretty high levels of overspend in initial submissions, although similar to last year's submissions when they first came in. I mean, the work done by you and with Jim's huge support and call on it looks like that those numbers have come within much more reasonable range, at least as a plan. So there's a few hundred million, more to do. And then much more to do, as we talked this morning at the board, and Jim talked at the board, making sure it's not easy to write the plan, but you've then got to deliver the plan. So actually that will take some very real work. And we also know, and Jim, you were very sort of strong on this morning, and wholly appropriately strong on this morning with Julian, that, there will be some plans in there actually where there's some real credibility issues that we've got to get after really quite quickly. So it's helpful that the initial step is much more reasonable to start with, but now that step's got to be sort of concreted in, and confidence in delivery increased and enhanced, I think.
Oh, absolutely.
And then the productivity challenge, 4% in the planning guidance. That's a hard challenge. It's an appropriate level of challenge, and it's good actually that we're just running at 2.7% in this latest year, but 4% is a step up. And if I had another just concern, it's also that a number of the measures that the various trusts and systems were taking last year may have taken, it's unfair to call it the low-hanging fruit, but as you go, is it harder to find sources essentially of effectiveness and efficiency? And it may well be so. It's a steep challenge still, I think.
It is, definitely. Absolutely. So what we'll do in the next few weeks is really key to get under the plans, work with people who understand the risk and how it's managed.
Yeah, very good. Go on, yeah, Amanda.
Just on that, sorry, but just because this is Julian's last meeting. So and you've mentioned fantasy plans, because there was, I think, quite a lot of anxiety over the course of the year we're in now, so thinking about 24, 25, about the kind of confidence in plans that ICBs and providers have put forward. I think, Julian, I can't quite put my finger on it, but the variance from plan that you're describing obviously does include the agreed deficit support and other things that were in people's start positions. But it feels to me, looking at this, that more systems are coming in on plan than you had perhaps anticipated earlier in the year. So I just wanted to check that I had interpreted that correctly, because that would suggest that actually some of that anxiety about plans not being as robust as we might want, have all wanted them to be, including local leaders themselves, have in fact proved unfounded, and people have come in on their plans, which, thinking about this year, would give us perhaps a little bit more confidence.
Yeah, I mean, I've always thought we would do better than last year. I think we've probably managed to do slightly better than the better that I thought we might manage to do. You can still see, in fact, in Annex A, like, you can see the places that are really materially off, all right, and where you can see, well, either that, they had a plan, they just haven't delivered on it, or there wasn't really a plan there in the first place. I think the good thing looking into 25, 26, and last year was complicated by just how late everything, the total funding was agreed, and so this is it's a better place to be, because I think it does mean you can focus not on discussions about money, etc. You can focus on what's actually needed to be done to deliver it. And I think in the conversations I've had with some of the systems, I think they're more realistic about what still needs to be done, even over the next 1, 2, and 3 months. But it's like seeing that plan just really get, what's the word I'm looking for, made real. But as we've discussed elsewhere with Jim, I think there are 4 or 5 places, some of the ones I mentioned at the start, where I think right now it's, well, I'd say actually stronger than that. I think a turnaround approach is needed, and it's needed from the start of the year. It's like don't even wait. But again, I think we're in a better place to know where those places are, to take the action now. But it is plenty of challenge ahead.
Okay, so let's move on to the next item. Thank you for that, Julian. And also, that's your last CFO's report at the NHS.
What a relief.
What a relief. Well done. Thank you very much. So we're going to go on the NHS Performance Assessment Framework. I think, Steve, it's you and Adam, I think.
Thank you, Richard. We'll do a bit of a double act.
Assume the paper's read. There's a lot of papers. Assume they are read. That's the main point.
So, just conscious of time, we'll just step through some of the key points in here because it's a while since the board last had this in front of them. So, just to orientate colleagues, you'll be aware that we've currently got an oversight framework that is in place. That was last updated in 2022. And we've previously agreed with the system and within NHS England that we would review the framework and update it. And we did quite a bit of engagement at the time, and then colleagues may recall that we brought a proposed framework, an updated framework to the board in about June 2024, which responded or sought to respond to some of the feedback that we'd had. Some of that feedback was then built on by a formal consultation exercise that was run after the board considered the framework. The feedback from that indicated broad support for the proposals at the time. There were lots of different bits of feedback, but a couple of the groups were from ICBs that there was insufficient focus on the long term, and from community and mental health trusts in particular that there was less focus on their contribution compared to the acute sector. And at the time, there was a set of proposals that effectively bound providers and ICBs together. Obviously, after that point, the context changed quite considerably. We had an election and a new government, and the government issued an updated mandate to the NHS focusing on recovery and accelerated recovery around the constitutional standards and financial performance in particular, alongside a desire to really make progress on the 3 shifts and to move to neighbourhood health. And have also were and continue to be keen to make sure there is sufficient and appropriate public information about the performance of the local NHS from a transparency perspective, and that there's good accountability to local people for the performance of the NHS. So in support of that, we updated how we were describing the operating model for the NHS after that time, in around November it was, to kind of try and clarify the key contributions of NHS providers and integrated care boards, recognising that, of course, that was a point in time and no doubt that will continue to evolve. But that basically set out that providers would have a particular focus on high quality care, value for money, and a strong culture and staff engagement within organisations. And that ICBs would focus on what we described at the time as strategic commissioning, so a big focus on understanding of population health, arranging services in a way that would start to move towards that left shift and implement neighbourhood health, and would have a particular focus on utilisation and care management as well. We published at the time 2 documents called the Insightful Board to try and help providers and ICBs focus and strengthen their governance arrangements in that context. And all of that said, it's really therefore clearly important that whatever assessment framework is in place for the NHS, it reflects all of those changes that have occurred since we were last with you. And so we've continued to do work with the department to try and make sure that the framework which you've got in front of you today, or in your papers rather, reflects some of those shifts and changes that we've seen. And in the last couple of weeks, we've been able to and had the benefit of engaging with Penny and Jim about where we'd got to, and then therefore what the right set of next steps were. So what you've got in the pack is the proposed assessment framework for 25-26, so that the NHS has got clarity about how it will be assessed, how we'll identify areas for improvement, and to guide where enforcement action might need to be taken. And it also sets out how we'll assess the capability of integrated care boards and providers. Adam's going to run through just a bit about the mechanics, so I think it's important that colleagues are aware of that. But it's also important to just highlight to the board that, of course, what is what is with board colleagues today is quite different to what we consulted on before. And of course, the environment and circumstances continue to shape and change. And I'll say a little bit about next steps at the end, but there are a couple of points just to highlight. So one is that the changes, the key changes that have been made are set out in the annex so that colleagues can see those. And the second thing is this is an important part of the puzzle in the NHS in some respects, because quite a lot of things might hang off the oversight framework as they have indeed in the past. And recognising that it is different and that the environment continues to change. We'll come back to this at the end, but what we're proposing here in agreement with Penny and Jim and colleagues at the department is that, subject to board approval, the framework would be tested with the service and would be subject to a further formal consultation. So I think it's just important to say that. Then I'll maybe just frame that point at the end when Adam's done his bit, if that's all right.
Thanks, Steve. Afternoon, colleagues. So the framework works in a way where each ICB and each provider is allocated a form of segmentation. So one highly performing, four poorly performing, and there's an additional segment 5 we've introduced where we will perform a diagnostic in all segment 4 organisations to ascertain whether or not we should place them into recovery support going forward. The framework looks at a balanced set of measures across a number of domains, and it's been interesting listening to the discussion today because you can almost tick in the annex the kind of measures that people have been talking about when they're describing keeping people out of hospital, non-conveyance to ED, all those areas. So it feels pretty prescient when we look at the discussion at the board today. What I would say, though, each of the organisations, they are very different. So we've tried to allocate the kind of measures that you could directly say that is a kind of ICB-driven measure versus what would be an ambulance trust measure going forward. Important to note that primary care is assessed through the ICB because of the particular relationship that we have with delegated commissioning into that area. But the measures were selected also by a clinical advisory group, co-chaired by our CNO and one of our incoming co-medical directors. And they've worked really, really hard within the organisation and through the system to make sure that the measures were right and appropriate. The framework allows for an annual update, and I think to Steve's earlier point, if things change with the 10-year plan, there's the ability to put different things in and out depending on the pressures or the requirements in any given year. But the key part for this is, in the last time we took this to the board, we talked about how the system was pulled together in how we assess how things operate. In this model, all of the providers will be given a score regardless of what happens around them. However, the ICBs, because of their strategic responsibility to allocate resources, if they're in a system where they may be with their score performing well, but a provider within that system is not, they will have their score moderated because we would expect them as the leader of the system to therefore be held to account for making that work. Our aim is that the organisations in segment 1 are given as much autonomy as possible, and that's quite clear to us. But also it's really, really clear that in 3 and 4, we will give a targeted level of support, but also enforcement actions where required for those organisations. And as I said earlier, segment 5 falls into recovery support. We aim to test these operational plans as they come through. So Julian's covered that earlier. We do want to make sure that all systems know in the plan that they've submitted, this would be where we think, if you deliver that plan to what you've said, that's where we think you will land this year. We just think it's important that they know, in submitting what you submitted, we would put you at a segment 3. Do you want to do something now to kind of intervene to improve that going forward? In terms of leadership, the last time we discussed this with you as well, there was the mechanic where we could use the leadership score to moderate an organisation up and down. In this model, we have removed that quite formally, but we will now put in a formal way of assessing the capability of ICBs and providers to give a leadership rating for both those organisations in quite a formalised way. We're using the 4 main purposes of ICBs to assess that, and we're using the insightful provider board model to therefore assess providers. Finally, and really quite important for us, is there are 2 things we know will happen and come forward. One is the 10-year health plan, so that will therefore need some adjustment going forward. But also we know there'll be further reviews coming out in short order in relation to quality and also oversight. So it gives the ability to look at any of the domains going forward to therefore get that right. So as we do this testing and consultation phase, it gives us the ability to make some adjustments along the way to therefore get it right at that point. And with that, I'll hand back to Steve.
I can be super brief because Adam's just said what I was going to say. So I think the key bit is to say what the board's being asked to do is to recognise the environment and the context for the changes, to approve the framework, noting particularly that it will be subject to testing with the service on plans as well as more broadly, and that it will be subject to a formal consultation. And that then a final framework would be agreed by the end of Q1, and the first formal segmentation decisions would be taken at that point and then published in July.
So I'm going to hold us and just ask the board if they would support that. I mean, the key points: co-created, widely consulted on, clinically consulted on, autonomy, autonomy given for strong performance, and the great NHS phrase of support given to those where there are real challenges, and it's going to be further consulted on, which is, I know, is something that you and the DH want to think about. And particularly helpful, I think, is that you've been engaging with Penny and Jim on this, and it can flex going forward as things might change with future policy changes or other programmes. Do you want to say anything on it, Jim?
Yeah, just a couple of things. So there's a huge amount of work gone into this. So Steve, Adam, Miranda, and other colleagues have been working on it for a long while, and this is very complicated. So there's a desire out there, or for all of us, for this to be as simple and as clean as it used to be in the old days. Yeah. But the world we're in isn't as simple and as clean as it was. So there'll absolutely be things that we'll have to tweak and adjust. Yeah, so this consultation process is really important, that people actually do come back to us and point out the wrinkles that need to change. And then, as Adam said, when the 10-year plan's published, there'll be a bit of correction then as well. And we'll get better with it through the year. But, you know, let's understand this isn't something that can be perfect at the first go.
But it needs to be, but clarity will be good. So I'm going to move us on.
No, I think it's quite important, actually. In the mental health, I just wanted to ask whether we had thought through this discharge within 60 days being the responsibility of the mental health trusts, because the proportion of people that are in mental health beds in the independent sector funded by us that are staying for more than 60 days is actually quite significant. And I wonder whether we should also hold the ICBs to account for that, because that's their responsibility rather than the mental health trust.
This is page 93 of 147, I think. But is that something you want to respond to now?
I think Mary's point is very valid. We probably wouldn't change the framework because the framework doesn't apply to NHS independent providers of NHS services. No. However, Mary, you're absolutely correct that you would expect a good commissioner faced with a provider that had those circumstances, if they're an independent sector organisation, to be using their commissioning levers, he says, hitting his phone, to lever change with that. So that's what you would expect to happen in practice.
Great, thank you.
Is that right? Okay, so can we... Of course you can, yeah.
It'll be quick. So I think it's terrific, and I think it's almost comprehensive. There's one, to my mind, one absence, and that is there's no mention of research. There's no mention of research. And I would say research is not just a nice to have. I think it's in the Constitution. It's good for patients to be careful in a research-rich environment, better outcomes. But it's also key to sustaining innovation that we're going to badly need. So I just wonder if that could feature.
Richard, are you happy if I quickly respond to that?
Yes, so yeah.
Prepared, not happy. Robert, one of the domains is wider economic development and social contribution, and that includes some measures around greener responsibilities and also on research. But because of the sort of nascence of the data flows and various other factors, although they're in the framework and we will publish the data, it doesn't inform the formal score. So it's like a contextual piece at this point, but there is a metric on research that we agreed with Vin's team after the board development session, the exec development session a while back.
So, Penny, do you want to comment on this at all at this stage? I mean, Jim.
Well, it's a great start. I think it needs a bit of tweaking working on, which I already shared a bit with Steve. But I think we do that over the next, however long the consultation period is. I think we can input at that stage.
Very good. Okay, thank you. I am now going to move us on, having tried a couple of times. So, cancer programme update. Peter, welcome. Rob, welcome. Are you going to lead in, Peter? Or Emily going to lead in?
I'll just say very briefly.
Sorry, please, yeah.
So this is the biannual update to the board on delivery progress for the National Cancer Programme. It is a summary of the latest performance, progress on, for example, the earlier diagnosis agenda and some of the national initiatives that have been driving improvements. The report details some fantastic achievements, which I didn't spoil earlier and I won't spoil now, so that the team can talk about them, with the main result being more patients being seen more quickly and diagnosed earlier, and focused on the people and communities who need it most. And the paper also outlines the work to develop a national cancer plan, which is being jointly developed by NHS and DHSC, and which will be published later this year. So over to you guys.
Thank you, Emily, and thank you, Chair. My name's Rob Stones. I'm Director of Delivery for the National Cancer Programme, and joined by Professor Johnson, who's our National Clinical Director for Cancer. I'll take the paper as read. I'll give a brief summary of the key points in relation to operational performance for cancer and on early diagnosis. Peter will then go on to describe a bit of the how we've achieved some of these areas of improvement. I'll start with early diagnosis. So after the best part of a decade, we've had fairly flat performance on early diagnosis. That is the proportion of cancers being diagnosed at stages 1 or 2. It's stayed very constant at around 55 to 56%. We've seen some real and steady improvement of around 2.8 percentage points on that since 2019 in the most recent data. So that takes the overall rate up to around 58.7%. And if we convert that into patients, that's over 7,300 more patients per year being diagnosed at stage 1 and 2 than before the pandemic. So very real impacts on real people. Lung cancer screening has been a really crucial driver in this. That is using mobile imaging diagnostic capacity, i.e. trucks, to target lung CT scans at populations that need them the most, as well as helping to drive up that overall early diagnosis rate. It's been a huge success story in also being able to target some of the most deprived areas versus the least deprived, and we've seen a narrowing of the gap in that story. So that's been really, really positive. Moving on to operational performance then, for the current financial year we're in, we set 2 targets for access through 24-25 both to be achieved by March 2025, which we're nearly at the end of said month. The first of those 2 was for the 28-day faster diagnosis standard, that we would improve performance to 77%. And the second was for the 62-day referral to first treatment standard. We set the ambition that we would get to 70% on that. We are on track nationally to hit both of those targets. In the third quarter of the financial year, we were at 77.5% for the faster diagnosis standard. That's just over 5% higher than last year. And on the 62-day target, we were at 69.6%, so 4.6 percentage points higher than last year. Both of those indicators are subject to quite considerable seasonal variation through the year. And while performance tends to dip typically in January, and we see that in the very latest data we have, in particular for the faster diagnosis standard, we typically see that very quickly recover into February and March. So we're seeing the typical seasonal trends play out here. Things like skin cancer has a very seasonal pattern to it, as you would expect. We've set some further stretch ambitions for the coming financial year through the operational planning guidance. So for 25-26, we have a new ambition of 80% for the faster diagnosis standard and 75% for the 62-day standard. That's on our path as we hope to recover towards full recovery of the Constitution standards for cancer patients. We have currently 13 trusts who are in Tier 1, and our approach to tiering helps us to provide enhanced oversight and support to the systems that need it most. That's proven to be quite a powerful lever for us in driving focused performance improvement, and paragraph 5 of the paper demonstrates that. Here I just want to put on record my thanks to the 20 cancer alliances across the country. They do incredible work, and they really help to provide some of that targeted local support to places that need it the most. I'll pass over to Peter now to describe some of our work on the cancer pathways and some of the innovation, and as we look forward to the cancer plan, as Emily mentioned.
Thanks, Rob. The board will recall that we've done a lot of work to try and streamline and increase the efficiency and productivity of people for people with urgent suspected cancer referrals, and we talked a bit about this at our last session. Fecal immunochemical testing to triage people who present with possible bowel cancer symptoms is something which has made a huge difference to our colonoscopy capacity. We've now got 80% of those referrals coming with a fit test from pretty much a standing start a few years ago, which has been enormously helpful in freeing up capacity in that area. We're doing similar things with teledermatology using remote capture of images for review by a consultant dermatologist. We're at just over 40% of referrals accompanied by an image at the moment, and we'll continue to push on that. And I think the readout from that has been that we saw a much lower seasonal drop in performance with skin cancer than we'd seen previously. The kind of post-summer holiday bump that we always get was significantly attenuated this year. We've got significant challenges still in prostate cancer pathways. We're working hard to drive up the rates of local anaesthetic outpatient biopsies and training up the non-medical workforce to deliver those. We've also got pressures in the gynecological pathways, particularly driven by the huge rise in hormone replacement treatment, which results in abnormal bleeding in women past the menopause. And again, we're working with pathways up and down the country to put in place alternative routes to diagnosis and management of people with abnormal uterine bleeding, to make sure that we can preserve the efficiency of the endometrial cancer pathways. So a lot of work going on to improve efficiency, but I think the overall message is that we're progressively pivoting from a continuing increase in unselected cancer referrals, where we've seen a 10% year-on-year rise over the last decade, to trying to be more selective in our case finding, and the lung cancer screening program is an example of that. Other things such as looking at people at greatest risk of liver cancers by screening people with fatty liver disease, alcoholic liver disease, viral liver disease. We've referred 45,000 people for fibroscans to look at their risk of liver cancer development, and 3,000 of them are now on high-risk follow-up pathways to do that. Similarly, trying to understand hereditary risk, lots of work has already gone into finding people with DNA mismatch repair deficiencies, so-called Lynch syndrome, where we now have pretty much every case of bowel or endometrial cancer tested for mismatch repair deficiency to enable us to find those kindreds, and the database for that is expanding rapidly. Similar programs in detecting families with BRCA mutations. I think we've sent out 26,000 odd tests as part of the case finding program we've done, primarily aimed at the Jewish population, and have found an extra 300 people with BRCA mutations who were unaware of that, which again will have important consequences for their families. In thinking about innovation and returning to Richard's point about the cancer vaccine programme, our partnership in the Cancer Vaccine Launchpad has been very effective. We've got 55 sites across the country now, potentially offering people access to trials which would only historically have been run in about a dozen trial sites as part of the experimental medicine network. So we've gone from covering around 15% of the population with access to trials of this type of thing to somewhere north of 60% as things currently stand. And the consequence of that is that the first trial we supported through this in bowel cancer adjuvant vaccination closed about 6 months earlier than anybody had anticipated, because the UK was recruiting faster than the rest of the world put together to that particular trial. And the consequence of that is that we are now attracting a great deal more interest from different companies with personalised vaccines to test. We've got another 2 trials opening in the next couple of months and a progressively expanding portfolio, which I think is very important, not only for the development of research, but also for the setup of business as usual type pathways to support these kind of innovative treatments, and very importantly for the penumbral effect that it's had on bringing together our histopathology and genomics services to streamline that process, which has historically been something of a bottleneck for genomics. The work on the cancer plan is actually extremely helpful. The close working that we've got now with the Department of Health team, we've set up the various structures very much jointly to make sure that we're delivering that, and the great majority of clinical advice to the cancer plan will come from our NHS England clinical advisory groups. A big focus obviously on the strategies which will most improve survival from cancers, and we anticipate that there will be a continued focus on earlier diagnosis, more effective pathways to diagnosis and innovative treatment. And I think in thinking about that, we are anxious to make sure that we retain a degree of system-facing national oversight for the process, linked to the very successful work of the cancer alliances, and a lot of the things that we've talked about have critically depended on the presence of locality-based cancer alliances who understand their populations and who are capable of enacting both the national programmes and local initiatives to drive up performance and delivery. So those, I think, will be key priorities for our development of the cancer plan as it goes ahead. And in the year ahead, obviously, we will continue to focus on driving up the performance, as Rob has outlined, back towards the constitutional standards, and to continue stretching the faster diagnosis standard, where we've already gone above what we set as our baseline. And we can see that in order to meet the 62-day wait standard, we will need to continue to push harder on that to squeeze down the diagnostic times. So we will continue to do that. We will continue to deliver the programmes, and very importantly, the rollout of the lung cancer programme, which is now just under 40% of the population covered, and we need to continue to accelerate and expand that in order to get the benefit that we've already seen as we've started, and of course to continue to drive some of these innovative programmes. And we've talked previously about some of the diagnostic innovations, and we're waiting to see, for example, the result of the big multi-cancer early detection test study, which will emerge in the early part of 2026.
That's very good. So let me open to. So I've got Andrew and Duncan first. Andrew first, and Duncan.
Fantastic progress. Yeah. Really is fantastic, and it's great to see some step change in terms of improvement. On the 62-day standard, though, Peter, what's the big constraint now? Is it physical bed capacity, or is it manpower, or is it a combination? Just to understand, what are the things that you're doing to lift a further 5% improvement in performance?
And we're going to do the normal technique of batching up the questions, if that's all right, and then so then I think it was Duncan, then Jane. I think Duncan.
Yeah, look, some amazing stuff in here. I spent a bit of time in the Maggie Centre in Charing Cross a couple of months ago, and I was meeting with women who had gone through crash menopause as a result of their cancer treatment. And the thing that really struck me was how important that relationship with clinical nurse specialists was, but also that peer support from other patients. And I just wondered whether in your prioritisation of things for the coming plan, areas around improving that experience, and then also thoughts on the importance of the workforce, because there is a whole, as you well know, army of people that are there for patients at all hours of the day, at some of the most difficult times of their life, and just in the midst of all of these brilliant pieces of work, it's just that is the thing that often people talk about in terms of their experience.
So I'm going to quickly gather, there are 3 more questions coming, and then in the interest of time you'll be batching and then allocating. So it was Jane first, and then Robert, and then Julian.
Thank you, Chair, and I refer to my declaration of interest as a trustee of Action on Smoking and Health. I guess that with the age of sale legislation, on its way through Parliament, there's a feeling, I think, from a lot of the sort of people who've worked to sort of decrease smoking over the years, that there'll be a sense of a lot of people think job done, but actually the sense is, I think, rightly people think we will see that greater concentration, particularly in areas that have already got a lot of health inequalities and disadvantaged communities. So I just wondered if you think in the years ahead there's more opportunity to join up the NHS around the prevention agenda, in as much as sort of a lot of the people will be people, as you're already showing, who, if you like, can be identified by some of those other risk factors.
Do you mind if I keep batching up for you? Well, I'm not batching you. Robert, and then Julian.
Yeah, no, great paper and lots of terrific stuff happening. And you refer to innovation, and you talked about the cancer vaccine, Peter, which is really very exciting. You're well aware there are other innovations in checkpoint inhibitors and CAR T cells. CAR T cells purely in trials at the moment, I think. Checkpoint inhibitors licensed for use in melanoma only. Is there an affordability challenge coming our way if more of these things get approved for wider use?
And then Julian.
I think our cancer programme is one where we should really learn some lessons about how you can make some change happen, and change that people have tried to deliver and haven't delivered actually for quite a long time. And the early cancer diagnosis is a really good example. And it's where targeted funding, nationally targeted funding, can really make a difference. Carefully directed, well program managed. Two, where how you learn how you take innovation within the NHS, and actually the fit test I think is a really good example, but it's national impetus that gets it scaled and rolled out, and that like a simple thing that's made a huge difference, as Peter's said, to broader capacity, and where well-placed rules. I mean, we have hit the faster diagnosis standard, which we were struggling to do pre-pandemic, and it's where some of the additional investment, but the kind of rules we have set, I think, have made a difference. And I do think, it's easy to get the argument, don't ring fence anything, careful how much national direction, but I think there are some lessons to be learned, which carefully applied can make a huge difference as we think about how we deliver the 10-year plan.
So you've got the question. Emily, do you want to come in either?
Just very briefly, I would have said some of what Julian said, but he said it much better than me. The thing I wanted to mention, which I'm sure the team would have done, is to recognise the work of Callie Palmer in delivering that. So Callie's just stepped away from this role after 10 years, and we were at her leaving drinks last night talking about the extraordinary impact that she's had in leading and spearheading that, and I wanted to recognise that as part of this discussion.
No, absolutely. Thank you. I was going to come to Callie at the end, but
Sorry.
Fantastic. Thank you. And thank you, Gillian, for the comments. I think whilst ring fence funding is clearly problematic in many ways, actually having a cadre of people, particularly at local level, who get out of bed each day working out how you deliver better cancer services, how you deliver better performance. And one of the things that we did in the last few years was to switch alliances from being what I previously referred to as gloriously strategic to focusing more on delivery and performance has had a huge impact on the ground, because they understand their providers and they understand their populations, and also of course they can put in some targeted funding to the bottlenecks. So I think that has been very important. It also speaks to Duncan's point about the patient experience, and again the Alliance has done a huge amount of development. The Accend programme for the training of clinical nurse specialists has been really important to make sure that we continue to grow that cadre of people where we see quite high turnover. People come in, train, and then move on to other things in their lives. But it's really important that we continue to develop that, because you're absolutely right. It's the thing that patients notice most of all is the clinical nurse specialists to whom they talk, who deliver their chemotherapy and who do all the other things that they do. So really important. And living with and beyond cancer is clearly going to be an important component of the thinking in the cancer plan. The difficulty, of course, is to make it strategic and effective and not try to do absolutely everything with the plan. To Andrew's point about the 62-day wait question, the investment in diagnostics has clearly been hugely important to helping us to deliver the faster diagnosis standard, and squeezing down diagnostic time has helped enormously. The bit that we're now seeing is the next point in the chain, which is the time to treatment, and particularly what we see is a stretching out of operating time for cancer surgery, which of course is about half of all initial episodes of treatment. And there is a tension between elective recovery and use of operating theatres for that and getting the cancer operations done. We're starting to see some helpfulness from the surgical hubs, which do a relatively small amount of cancer operating. They mostly only do skin and breast cancer operations, but what that does do is free up time in the acute units to get more cancer operations done. And that's again thinking about how we improve theatre productivity for cancer surgery is going to be important. Radiotherapy is the other area where we've seen waiting times start to edge up. And again, the renewal of the linear accelerated programme, and we've put significant capital investment into that recently and plans to continue to do more, is going to be really important to continue to do that. We are hoping to implement AI contouring to speed up radiotherapy planning, because as radiotherapy becomes more sophisticated, you need longer time in medical physics and clinical oncologists to plan the fields. Having AI to do that significantly shortens the time and frees up specialist time to do more. The budget challenges have meant that we haven't rolled that out as fast as we had previously intended, but nonetheless we've got suppliers lined up to help us with that, and we'll continue to try and push on that during the year. Prevention absolutely is going to be critical again to the cancer plan, and one of the non-NHS England domains of the cancer plan where there is a specific work stream is in prevention. Really interesting to see recently some projected reductions in mortality, where it looks as though the UK's projected mortality reductions from cancer are going faster than other European countries, and I think a lot of that probably has to do with the faster change in smoking habits that we've seen as a consequence of previous legislation and things that have been done in that area, but very encouraging to see that. And finally, yes, in terms of delivery of sophisticated therapeutics, CAR T cells are now in routine use for acute lymphoblastic leukemia and high-grade B-cell lymphomas on a routine basis, and in fact are coming forward in the treatment algorithm for high-grade lymphoma, so they're being used in first recurrence now. So significant pressures of delivery. The next thing coming down the line is CAR T cells for multiple myeloma, where the prevalence is very much higher because there are many lines of treatment, and we're examining how we continue to expand that, moving to more ambulatory models of care as the experience with those technologies increases. And checkpoint inhibitors, similarly, we've got a huge number of indications for the use of checkpoint inhibitors now in multiple different cancer types. The challenge there is the uncommon but important toxicities that you see, and what we're in the process of doing is setting up a network of expertise around the country, so that when you get your autoimmune enteritis or thyroiditis or pituitary failure, you've got the relevant team that can manage it without you necessarily having to travel a long way to get that support. So lots of work to do to make sure we put the systems around the patient.
I'm going to close this item off. Whenever you come to the board, Callie will come to the board, and Rob, you come. It's always an extremely, I'm going to say, rich topic where we see amazing progress, but battling a huge scourge on our population. But actually, the innovation that you talk about, as well as actually, it is innovation, but it's the rollout of things like the lung cancer, the lung trucks. Remarkable, and the fit tests and the cancer alliances. There's huge amounts of progress being made, but we're continuously battling this rising demand, I think. But thank you very much for a very good presentation and conversation, Emily. Thank you very much. So we're moving to the last item, for which there is a sort of a discussion paper. As always, you know that if you go last, you get squeezed. And anyway, it's Data, Digital and Technology. It's a very good paper you provided, but do you want to give us the highlights?
Yeah, thank you, Chair. So I'll just say one word of it, a sentence for introduction, and then just make 3 key points. So first, can I just say it's a delight to be in Leeds today, not just because Leeds is a great city, but 2/3 of our digital staff work in our Leeds office. Right. And Richard, I was really pleased to hear you say at the beginning, we manage the data with our national digital and data services for more customers than Amazon UK has and more subscribers than Netflix has. So we're a very big provider of digital services, and that's really important. So I think there's just 3 key points I wanted to make. So number 1 is that we all know digital maturity in the NHS lags behind most other developed health systems by quite some considerable margin. 11% of our staff only 11% say they have the basic tools to do their job, and 70% of our staff say that our systems do not interoperate or talk to each other, and that means is a prerequisite for delivering the kind of community-based neighbourhood care that we've described, and digital maturity in community services is worse than it is in the acute sector. Secondly, we've seen from recent reports, just your basic experience as a patient, when you try and find out what's happened when you ring up a service and you've been referred by somebody else and somebody can't talk to somebody else's system. So we've got to sort that out. So I think secondly, the changes that we've described in this paper, which is what we've been doing in recent years, are fantastic, but they're necessary, but they're by no means enough. And so looking forward, fixing the digital infrastructure, it's really fantastic that by the end of next year, every trust in England will have an electronic patient record. But in the next phase, we've got to focus on interoperability. The second bit is it's fantastic that we procured, as NHS England in 2023, the Federated Data Platform. In the first wave of trusts that we've implemented that in, we're seeing an extra just over 100 patients per month being treated where they've implemented the surgical model. And of course, for the next year, we're going to crack on and continue to roll out the Federated Data Platform, and most importantly, to actually start testing new innovations that we can develop in the Federated Data Platform with other suppliers that we can then evaluate and then spread across the rest of the network. For the NHS App, and you'll see in the paper, we've not just implemented digital telephony and digital triage in primary care, but you can now request an appointment through the NHS App. But in the next phase, everyone complains about the fact they get a paper letter as well as a text message from their supplier. The NHS App will send you a message free if you turn the notifications on, and that means we could send 36 million fewer letters in the NHS if everybody turned the notification on. And that's why in our planning guidance we've asked all organisations to start asking patients if they'd like to receive app-based messaging alone, and we'll be pushing on that next year.
Paper, so I don't get multiple letters as well as...
You have to do both, yeah. Obviously there are some situations where members of the public may prefer or for various reasons reserve paper, but that's why we're asking people first if that's what they'd like to do. And then finally, we nationally did a deal with Microsoft for the Microsoft 365 platform. It saved the NHS millions of pounds, and the focus in the next year is going to be on maximising the benefit of that national deal so that everyone adopts all the features in that. So just the final point I think I wanted to make is that, I mean, you'll see from announcements in recent days, I think the government shares our ambition for digital technology and for the digital professions across government, particularly in the NHS. We're having very productive conversations with government. I think it's not so much a question of whether government wishes to invest in technology going forward into the spending review, but just how much can the NHS actually go forward and do it. And I think that's great to have that vote of confidence. Those are going to be key, I think, to delivering productivity, to delivering performance and getting a grip on the money, all the things that we've spent this board talking about. And I feel certainly really positive about the future, about what we can achieve with technology.
So thank you for the oral presentation and actually also for the deck. Thank you. I'm going to open up for comments. Mark, would you like to comment, because you chair the digital technology committee? Yeah.
I think I love the tone that Vin has struck. I think that tone is a direct reflection of the recent engagement with the government and the Secretary of State. I think the digital transformation of the NHS offers the route out of where we are today. And I am full of hope that if we commit, there is a dramatically different and better place for patients and our colleagues out there. But it's going to take time, and what this needs is consistent year-on-year discipline and funding.
Steady investment.
But there is a dramatically different world there.
Yeah.
For everybody.
Yeah. So comments or questions for Ben? I mean, I have one which is just I always ask you this actually, and so it's my very parochial question. It's just the power of how do you think about the power of the NHS number as a single customer identifier and spread and going beyond health and into other sources of data on population that actually can inform us on health? So is the NHS number really getting a good foothold in terms of being the aggregating identifier point?
It is the aggregating data point that we all use. We're the only health system in the world that has a linked data set linked by the single unique identifier. It's the only unique identifier that you have from birth, so you don't get your national insurance number from birth. Yeah. And so, it's absolutely critical.
But is it capturing other parts of the data we gather from other systems outside health?
Yes, so at the moment, your NHS number is not used, for example, for local authorities or, for ONS statistics or for education for that matter. But what we have been successful in being able to do is to work with local government at a local level, work with the ONS to do the data linkages across. And that's enabled us, for example, to get far more data on how what we do in the health service actually affects our lives more broadly on things like employment, on education and health and so on. So the numbers are absolutely fantastic. We're working closely with government about how you can go further on data linkages, and that will be one of the major pieces of work that we'll be doing over the next year.
Very good. Robert?
Multiple references, it's a great paper and terrific stuff going on. Multiple references to the single patient record, which we all crave for. What would you say is the timetable, and is it investment dependent?
Firstly, I think the single patient record, when we describe that, it is basically a record owned by the patient, which currently we don't have a record that's owned by us. As a clinician, the record sits with me. It contains all the information about you, no matter which part of the service you're accessing, primary care, secondary care, pharmacy first, whatever. And thirdly, that then you are able to make choices about who that information is shared with. It does mean all your caregivers can see it. It's a commitment that the Secretary of State made in his speech to the Royal College of GPs in October last year. We're currently working with government on and how that will be reflected in the spending review. And then actually, because we've not had anything like it in the NHS before, if we're successful in securing the funding, we will work with the technology industry and with other countries that we've already been meeting, like India, Estonia, other parts of the world who've got these, to work out how you might actually put it together, architect it and make it work for the rest of the system.
Any other comments or questions for Vin? I think Mark's captured it really well, actually, the tone of this presentation discussion from Vin, and actually if we can win through in partnership, clearly so supported by the Secretary of State and in the 10-year health plan, and we can actually capture steady investment, significant steady investment over several years, it will be utterly transformational, I think.
It will. There's another point to Robert's question about the single patient record. The single patient record will unlock a much better treatment pathway for all citizens. It will unlock amazing efficiency for our colleagues. Yeah. And there are endless edge cases where you could argue for years about why you don't want to do it. And at some point, as a board, as the government, as the custodians of the nation's health, we need to stop arguing about edge cases and start dealing with the vast majority of society who desperately need this. Because we are going to get dragged back into the long grass with things that actually, in all probability, will never happen.
Very good. So, Steve, I'm going to put Rob and Peter back on the on the stage, because you were going to ask a question, I think, when we were doing the cancer discussion. Would you like to ask it now? Because I've created some... Only if it's brief, though, Steve.
Well, Peter might have covered it off. I couldn't see it jumping out of the paper, and apologies, I couldn't hear everything. It was about inequalities in cancer and what progress is being made in all cancers or certain cancers in addressing health inequalities, and what do you see as of the prospects in terms of diagnostic approaches, etc., of doing that in the future?
Thanks, Steve. Sorry, you weren't expecting me to come back, but what we've seen in the lung health checks programme, as others have alluded to, and I think maybe in the paper, is that having started running them in the communities with the highest rates of lung cancer and the highest rates of late diagnosis, which of course is the most deprived communities, because it's an effective way of picking up lung cancer at an early stage, we've inverted the relationship between deprivation and stage of diagnosis of lung cancer. So you're actually more likely to have your lung cancer diagnosed at an early stage now if you're in the most deprived quintile. And that, as Julian alluded to, is a reflection of the fact that if you put the investment in a very specific and targeted way, we are not the sort of helpless recipients of the social inequalities of health. There are actually things that we can do to influence it if you get it right. Now, there's not an infinite number of interventions like that, but what I think it speaks to is more specific and targeted approach to finding people or giving people with the high potential of having those illnesses ways into the system that we've not done. So simply waiting for people to turn up with symptoms has not historically done what we need to do. Working out who's at highest risk, working out how you target them, using the local knowledge and the cancer alliances. So the West Midlands Cancer Alliance, working with their Afro-Caribbean community, have done a massive amount to raise awareness of prostate cancer among that group, as a consequence of which we actually see people with black heritage presenting at an earlier stage than people with white heritage, because the community groups have been engaged to raise awareness and get people coming in to get checked. So I think there are things that can be done. A lot of it is quite local, because you have to understand your community, but there are also some things that we can do at a national level to move the dial on that and work out how you really get the healthcare to people rather than waiting for the people to come to you. And I think that's going to be a really important component of how we think about the cancer plan.
So thank you, Steve. Thank you very much, Peter. So there are 3 more items. There's the annual emergency preparedness, resilience and response assurance report. I know, Emily, you've kindly provided it. It's a starred item. I'd just like to say we had a good discussion about this in this morning's private board, and just to reflect, we should note it and also recognise it's a continuously evolving picture. And we had, as I say, a very good discussion, and we're looking as we go forward both to improve and amend actually some of our practices and some of our tests of resilience. But the board should just note this report in its current state. And the other 2 reports, again, just for noting, there's the directions and mandatory requests that we receive essentially from the Secretary of State. One is under the Notify Service Directions. And the second is National Proxy Service Directions. So we've had those from the Secretary of State, and the board's asked to note those new directions and the information provided in the papers.
Yeah, and just those are absolutely critical to moving to paperless and also to proxy access for carers and for parents to their child's NHS App. So they are important.
I saw that, yeah, the proxy, and I saw that. Even more of a reason for no board member to vote against those, I think. And then lastly, we've got the report on the use of the NHS England seal, where, Julian, you have been extremely busy again. And there's a long list of documents signed and sealed with the NHS England seal, so we can just, for information, note those. Is there any other business before we close, just going around? Well, I'm going to finish then just with my thanks, obviously, to board colleagues and executive colleagues. And also, as I said at the start, actually, frankly, to all frontline staff and all chairs and leaders across our system. So it's an amazing workforce, and we should note our thanks to all of them. But just for the purpose of this meeting, very specifically, my thanks to the board and to our executive colleagues. A number of us are going as of Monday, actually. So Amanda and Julian and Emily and Steve. Particular thanks for your actually friendship as well as your huge executive commitment and the performance as execs on the NHS England board. To Penny and to Jim, who I know has had to run. To Penny and to Jim, we wish you all the best success. It's a sort of remarkable, almost chalice to be handed actually, and so we wish you all the best success with it. It truly matters. It is such an important part of our society. So thank you very much. And at that point, I was trying to think, we discussed winter earlier with Sarah Jane, which prompts me to sort of say, as at the end of The Winter's Tale, exit stage left, pursued by a bear. But anyway, thank you very much, everybody.